the head facing down is what's going to allow the most natural transition for the body to deliver a baby and go into labor. So the baby is breech, or footling breech, complete breech, transverse, shoulder presentation, face presentation. There's so many, you're going to learn all of them. Or maybe the fetus is too big. Maybe there's twins, triplets, quadruplets, 8 of them. You have to be realistic, right? We're not dogs. We can't just pop them out that easily. We don't have that innate connection anymore. The other two, really important, people forget, is the psyche. I've had patients who get to 10 centimeters and then they just lose all hope. And their contractions stop, the baby doesn't go down, and on top of that, the baby does not do well. Because the maternal psyche disrupts the fetal circulation because of anxiety, mental distress. So we all have to maintain, as we're guiding the birthing person, we have to make sure that they're also mentally prepared for this. Because often this can actually change their vital signs, right? How many of you have seen vital signs shoot up if you're a tech? And it's not a diastolic, but that top number that was 130 just shoots up to 160, and you're like, it's just anxiety, but it's not just anxiety, right? There's always a root cause. And finally, the position, and this is different from the passenger position. This is actually how the maternal position can affect labor. If any of you have seen or been through labor, a lot of times we do not like to keep you in one position for too long. And this is because as the contractions are happening, it's bringing the baby down. The maternal or the birthing person's positioning and how they turn constantly is what rocks that baby down. So keeping a person laying on their back for 15, 16 hours with an epidural is not going to help that baby go into the best position to deliver. This is a good picture. If you look at, can you see the cursor? Okay. So this is the bone we're talking about, right? That's the passage. The passenger is facing down. This head, it seems really obvious, but it really is the most crucial beginning to our bodies feeling that need to go into labor. And again, the contracting uterus is up here and it's pushing down. If you're curious what this is just an animated version of a placenta. Placentas are not always in the same place, so don't just equate that as every pregnancy. Like I said earlier, contractions are described in frequency. We use minutes, so how often they are. We want them to be 2 to 3 minutes if they're in active labor, or at least going into labor. We want them to be long enough. We want to be at least 60 to 90 seconds long, and intensity, we want them to be at least moderate to strong palpating. As you go into your clinical rotations, you're going to notice contractions feel very strong if they're strong. Your nose is a mild contraction, your chin is a moderate contraction, and your forehead is a strong contraction. That's how you would palpate the fundus. The fundus is the topmost firm part of the uterus. You will have to palpate that during your clinical. This is a visual way of recording and measuring how frequent contractions are. When we measure how frequent they are, we start at the beginning of the contraction to the beginning of the next. So we don't do in between. We don't say 4 minutes apart. We say every 5 minutes. So we start at the beginning, 1, 2, 3, 4, beginning of the next 5 minutes. So this frequency is 5 minutes. The duration is the beginning of the contraction to the end of the contraction, and we use seconds. So this is about 60 seconds. Even if the contraction is 2 minutes long, we still say 120 seconds. Even if I explain this to you, I don't think you understand, but in this example for here, these contractions are 1, 2 minutes apart. You see that? Right, this is 1, 2.5-ish, 1, 2. So this is like my language, so I might be doing it a little easier. I'm sure some of you guys know how to read telemetry. I can't read telemetry. But the bottom mountains, those are contractions, right? So contractions are always measured on the bottom half of the measuring strip. And the top is the fetal heart rate. So if you see here, you see numbers. You don't have to focus on that right now. But the top half will have fetal heart rate numbers, and the bottom, the numbers only matter if there's intrauterine monitors. So these are most likely external monitors because they're not as smooth. And in a few, I think next lecture after that we'll learn about it. I think 2 weeks ago, Dr. Pitts talked about how the contraction of the peak, you don't have any blood flow, and this is because it has to be that strong to allow the fetus to move and continue with labor. And the thing is, we require duration to be long enough but not too long, and we have that 60 to 90 second, we also have that 2 to 3 minutes apart, and the reason why we don't want it every second, every minute is because the baby has to breathe. How do they breathe? We're pushing them out. Well, when your contraction goes all the way to the top, that gray zone, there is no oxygen permeation between the placenta. Nothing. So how do they breathe? They use something called oxygen reserve, and that's in the placenta. Now, if that placenta is not working well, it's not going to have anything reserved, right? This is why we care about maintaining that maternal, that birthing person's health. We want to maintain circulation. We want to maintain psyche, mental health. Because anything that obstructs that ability for the placenta to maintain reserve oxygen will then immediately make that no blood flow zone dangerous for the baby. And then we call it the resting period in between. So once it goes back to normal flow, that's when that placenta is resting and it's refilling with oxygen again. Any questions so far? Good. Power, I talked about earlier, so we want strong, so we want that chin or forehead. That's when we really know those contractions are working. We cannot measure the intensity with external monitors. We can only palpate. So if you didn't touch your patient, you can't say how strong they were. The only time we can do that is if we have an internal pressure catheter, and that measures the pressure of the muscles pushing in by measuring the mercury, millimeters of mercury, in the amniotic fluid. That requires different types of measurement now. What if we are giving artificial oxytocin, right? Because remember, oxytocin is that happy hormone that allows your contractions to go faster, stronger. But if we're doing that artificially, we as nurses assessing the patient have to be very vigilant on how strong those contractions are getting. You want to touch that belly and think, in between the contractions, right? If the monitor says it's going down, is it truly relaxed in between? Because if you just type or calibrate the monitor to be set so that it looks fine, but you feel that resting phase and it's still firm and it still feels like your chin, then that baby's placenta is not resting or getting enough oxygen in between. That's a monitor from my baby. Cervical effacement and dilation. So dilation means what? What does effacement mean? Thinning, right? We use 0 to 10 and 0 to 100. So dilation, when you start at 0 centimeters, that's closed. That's the beginning stage of the cervix. And we go to 10 centimeters, which is the size of a bagel, right? And that is for a full-term baby, usually enough space for a baby to come through. Now, we give you measures, but if you're actually feeling the cervix, it usually, we say 10 centimeters when you feel no more cervix around the head. It sounds odd, but you can feel it, okay? When it's 10 centimeters, we usually say it's full dilation or it's fully dilated. She might use those terminologies for your exam. Effacement is a shortening and thinning, so the normal cervix that is not in labor is usually about 4 centimeters long. And it just looks like a little, like a passage, but just like very cinched, you see it right here. So when that starts to ripen, right, 0% effaced means there's absolutely no budge. It's no bounce to it, there's no flexibility at all, there's just nothing. What you do start feeling though is when it starts getting maybe 50%, you might be a little dilated, but you can kind of feel it, that it's starting to kind of shape around the baby's head. And when it's fully effaced, you see on the right side here, you can tell that cervix is really thinned out. But even before it dilates, you can tell because you can feel that head really forming in. It's very interesting. So remember earlier we said preemie gravida, here it says preemie para, that's someone who's never given birth before. Remember, parity is birth. Gravida is pregnancy. So premie means first delivery, okay? Those who've never given birth before will usually thin out before they dilate. So you'll start feeling that cervix getting thinner and thinner and thinner, and after that, the cervix dilates. Whereas someone who's had a baby before, they'll come in and they might be dilated, but they also might start thinning at the same time. So someone might come in like 6 centimeters dilated, but only about 60% effaced. So those patients, it might be their second, third baby, but it's really fun because I shouldn't say fun, but you can really feel what that cervix feels like. Now, when we go into labor, there are different phases, and we like to kind of talk about it as early, middle, and transition, although we don't use that transition thing anymore. We say latent and active. So latent is that early phase, anywhere between that, that lightning, getting into contractions, maybe not much change, but your body's getting ready. Active is when your body is dilating, it is thinning, that baby is coming down. You were expecting birth in the next 24 hours-ish, depending on what number baby is, or how your body is. There are two phases. I know it says 3 here, but we use latent and active now. That's why I wrote that /latent/active. I don't think it's on your guys's. I can post this on the chat later. But there are 4 stages, so don't get stage and phase mixed up. Those are 2 different things. Just another example of how dilation and thinning happens. Going back to passage. So remember we talked about gynecoid pelvis? This is the shape that genuinely is probably the best form. The other 3, there's android. This is the most common. Android and anthropoid are more common for males. There's also platyploid. I Googled this a few days ago just to not be able to, just actually be able to tell you guys. But I think back in the 80s, the United States stopped doing this, but even in Spain and other European countries, they still do pelvic x-rays to assess whether you are a good candidate for vaginal delivery. But the most important one you need to know is gynecoid equals vaginal birth. And I think it's easiest because gynecoid, gynecology, gyno, G-Y-N. Now remember, passengers come down, we have to measure how is the fetus coming down, right? How far are they in terms of the pelvis? When we do a vaginal exam, we'll use 3 numbers. We say centimeter dilation first, so if someone is 4 centimeters dilated, and then we'll say 60% effaced. We'll talk about the effacement. So it's centimeters / effacement, so it's percentage / and then it's either a number between -3 to +3. This is something that tells us between those that are caring for the patient on where that fetal head is located. We're not talking about the molding, we're talking about the actual head, the bone. Sometimes the baby's low enough, I can feel their ears going up and I'll say, oh, this is where they're facing, this is how they are. This is a really good way for us to know whether the patient's pelvis is allowing the baby to come through. But it's just really important for you to know if someone says, oh, the baby is at +2 presentation or +2 station, to you, would that say that the patient is almost ready to deliver or still in early labor? Almost ready to deliver, yeah. The other day I had a patient who was her second baby, and she was from like the moment, from the get-go, she was 3 centimeters +2 station, and I was just like, all we need is just break her water, and that baby came out. Yep, so we usually, the 0, so people often ask, well, how do you know if it's, where the 0 is? It's the pelvic bone. When you do a vaginal exam, you feel the pelvis, right? And in accordance to that pelvis, we then say, okay, where is that fetal caput? It takes a lot of work, takes a lot of experience. You don't have to understand how it works. Just know plus means further up, okay? I think really want to know. Rugae, soft tissue of vagina. So uterus, cervix, and then vagina, okay? There's like 2 doors for the baby to get through. Cervix is only the first one, right? 99% of labor is getting the head out, okay? It's not the body, it's just the head. And not only do the patients have to push through the bones, but after that, they have to stretch their entire perineal area out. They have to stretch the vaginal skin out. Everything has to mold around the fetal head. It is a lot of work, and it's called labor for a reason. That's an example of Brugag. Those of you who had vaginal deliveries prior may notice that your pelvic muscle down there may or may not be as strong as they used to. This is called pelvic floor weakening, and Kegels may help you a lot, but also don't forget, if anyone, this is totally fine for this, if you do have urinary incontinence, that's not something you have to live with. Please go consult a gynecologist or a urologist and get that checked out, because quality of life. Passenger, yes, we talked about that, head down, really important. When we say head down, we're not talking about arms out with head down. That's often an issue. That can cause complications. We also don't want umbilical cord out and head down, right? Because what is the umbilical cord? That's the breathing tube inside. Okay, don't forget that. Babies need the umbilical cord to stay active. At any point, if that string, rope, whatever you want to call it in your head, gets knotted or cinched, or often, as we labor nurses say, the babies are getting high off of squeezing their umbilical cords inside, you see that in their tracing. They look distressed, okay? Really important. So some terminologies you need to know for labor is molding. I said that earlier. Molding is when your brain, the fetal brain, and the sutures. So fetal skeletons, right? The brain is inside of an unattached skull. So there's a few pieces that aren't quite together yet. And that's so that the fetal caput can really mold in and allow that transition out. Molding is not life-threatening. It happens, we call it cone head, right? That's something that happens. Fetal attitude. So this is something that students often get really mixed up with a lot of other things. But we care about how the fetus is presenting in terms of where is their body facing, right? So where is their head facing? So sometimes babies can have an arm out, sometimes they can have arms like this, sometimes both their arms can come out. Whenever it says fetal attitude, think of it as what's their body language, right? So you want to think body language, fetal attitude. Fetal lie, think of it, fetal lie is the back. So the fetal lie is always how the fetus spine is positioned in relation to the mother. So if the fetal lie, you want to know which way it is, think of, well, in terms of the maternal spine, is the fetus back facing that way, like to the maternal right, the maternal left. These are just terminologies, but they do come up in your exam, and she'll say, well, what is the fetal lie in relation to? Something like that, right? And finally, fetal presentation. So, presenting the door. What's facing the door? The head, the feet, the shoulder, the face, the back. Sometimes transverse babies do go head down overnight. A lot of times, patients that come in and say, oh, I felt my baby moving a lot last time, I always ultrasound them before we do anything, because often that means the baby moves a little bit. So I was saying earlier, molding can happen because babies have 5 bones instead of one big skull, right? So there's that front, back, fontanelles, and the big suture that's open. There's parietal bones, temporal bones, and one occipital bone. Transverse measurement, we don't really talk about that too much, but it is about head size, sutures, you know that. There you go, another picture. That's a perfect example of molding. So you see those bones forming in to allow the best position. Just pay attention though. You notice the back of the head is what's facing forward? Now, imagine trying to mold if your forehead's facing forward. It's hard. That's actually something that we hate in labor. We call it OP presentation, occiput posterior. This is occiput anterior. If the head's coming out first with the back of the head, that's occiput anterior. Okay? Make sense? Alright? You always do things, okay. Okay. when we talk about the fetal head, right, which way it's facing, we always do it in relation to the maternal or the pregnant person's pelvis. So in the pelvis, and we're gonna have a picture of it later on. Okay, so remember, attitude, body language, fetal lie, spine, maternal spine. There. So when we talk about fetal presentation, we want to know is the back of the head, and the reason why we care so much about the back of the head is because it molds, right? The most flexible side is what we want coming out first. We want to know though, is it facing the right way, right? Sometimes it's not. Sometimes it's facing sideways, and that patient's pushing. But if that head doesn't mold, then we're just putting them through the biggest migraine of their life, right? It can change pushing from 30 minutes to 4 hours, okay? If you've ever seen videos of spinning babies, this is why we have to spin babies. It's not about breech to head down. We're talking literal spinning babies so that back of the head can go forward. And this is why a patient who just had an epidural should not be laying there on their back for the next 5 hours. You're not helping that baby turn at all. If you have a hard time understanding what these letters mean, R and L, right and left. Remember, pelvic presentation. Always occiput, because we care about the molding side. What molds? The occiput. And again, that can be posterior, transverse, or anterior. Okay? Let's go back. A lot of times you can assume what the fetal lie is based on where their head is. Okay? Because we can't just stick our hands all the way in to feel where that spine is, right? But we can also do something called Leopold's maneuvers. This will be on your vein. It's good to know that it's a 4-step thing. Nurses can do it. All you gotta do is feel that belly. And usually if someone's full term and they're like, oh, I think I'm in labor. As a labor nurse, I care more about, well, is the baby coming down? And if so, are they facing the right way? Leopold's maneuvers helps me at least get a hint on whether I'm expecting someone that has a well-applied in-progress fetus or a blockable fetus that's facing a different way. So the first step is we usually check how high is the fundus. We kind of push down. If I don't feel too much bounce, it usually means the fetus is well applied into that pelvic inlet and that lightening has occurred, right? The second one is then checking the fetal lie, right? We want to check for that spine. You won't always feel it, because if that baby is facing backwards, you're just going to feel a lot of emptiness on the side. Then the third is I will take my 2 fingers and check that lower pelvic right here, and I push down, and I check for that head. That gives me a good idea on whether the baby is well applied or not. But also, before I even check the application, it tells me if the fetus is facing down or up, because you can feel a difference between the head and the butt. How's your recording? Yeah. So we just got to, yeah. Okay. So remember earlier I talked about how the baby can face the wrong way, right? It's not just head down is good. So I said the face might be facing. So there's 3 types of breech: complete breech, frank breech, and foot-length breech. Frank is feet all the way up. Complete is that kind of folded pose. Foot-length, exactly word for word, the feet is coming out first. Unfortunately, currently, medically, we usually go straight to C-section for this. So if someone's getting induced and they are breech, we're thinking what? Right? They shouldn't be going into motion. With face presentations, they don't always know that. Sometimes they find out later on. But usually they decide on where the chin is. And the chin is the mentum. So again, according to the pelvis, is it left mentum anterior? Is it right mentum posterior? Right? So always based on the pelvis. Other ones. Okay, so as I said earlier, we want that patient moving. So these are really good positions to allow that active labor progression, but also physiological adaptations to allow that fetus to turn. So instead of being on your back, the partner can really help a lot of times through labor by providing counter pressure, hands and knees, sitting on a chair, rocking back and forth, walking, moving. We like to call this first position on the all the way to the left, the knee chest position. This is a position that as nurses we also use to alleviate any cord that the baby might be squeezing or locked up with. And the other two are really good to support with labor pain for patients that may be avoiding an epidural. All that. We discussed psyche earlier, and again, when you're caring for a patient, you might think that they're anxious, but it also might be that culturally or maybe their support system isn't as latched up to what their expectations are, right? Yeah. So say you're at a teaching hospital and there are male providers, right? Sometimes that might be the one thing keeping a patient from opening up. Or maybe their in-laws are in there and they really don't want to talk about something. Or maybe they haven't talked about certain things with their provider that only their partner, or maybe the opposite, sorry. Maybe they have talked about something to their provider that their partner doesn't know. Things like that. So a lot of times, this is why we're going to go in the next chapter, when you do that first patient intake, it's really important to allow that open communication and know the boundaries that you have to protect for your patients. Thank goodness for COVID, not the best, but we have limited visitors, and it has, I think, limited a lot of family issues that I've noticed. So that is chapter 16. Yeah.